Welcome to the deep dive. Today, we're really diving into an important topic. We want to cut through the noise and give you a clear, digestible understanding of bile duct cancer, which is also known as cholangiocarcinoma. Our main source for this is the American Cancer Society, really comprehensive stuff. Our goal, like always, is to pull out the key insights, the things you really need to know about this complex disease, its challenges, and importantly, the progress being made.
Yeah, and it's quite fascinating, how much detailed information is actually out there for a cancer that's, well, relatively rare in many places. So by laying out the basics, the biology, the stats, how care is changing, we really hope to give you a solid, well-rounded view that goes beyond just the headlines.
Okay, let's unpack this right from the start then. Before we even talk about cancer, what exactly are bile ducts? What do they do?
Right, so imagine you've got this network of really thin tubes inside your body. That's basically your bile duct system. Bile, this fluid made in your liver, stored in the gallbladder, it travels through these tubes, these ducts, down into your small intestine. Its main jobs: helping digest fats from your food and also helping your body get rid of waste filtered out by the liver.
Okay, so a really crucial part of digestion and waste removal. Got it. So where does the cancer aspect come into play here? How does it start?
Well, bile duct cancer, or cholangiocarcinoma as it's technically called, it's cancer that starts anywhere in that bile duct system we just described. And to really get a handle on it, it helps to know there are different types based on where they start. You've got intrahepatic cholangiocarcinoma. That starts in the smaller bile ducts inside the liver, makes up maybe 10% of cases. It's really important, though, to distinguish these from hepatocellular carcinoma, which starts in the main liver cells, because the treatment's different.
Okay, intrahepatic inside the liver. What about the others?
Then you have extrahepatic cholangiocarcinoma. These start outside the liver, and they're broken down further based on location. There are perilar duct cancers, sometimes called Klatskin tumors. They're found right where the main ducts leave the liver and join up.
Klatskin tumors, right. Heard that term.
And then there are distal duct cancers. These are further down the common bile duct, sort of extending through the pancreas towards the small intestine. Now, most bile duct cancers are what we call cholangiocarcinomas, which are a type of adenocarcinoma starting in the gland cells, lining the ducts. There are rarer types too, like sarcomas, but adenocarcinomas are the main ones.
That breakdown is helpful. Now, here's something really interesting about how common it is. This is actually a rare cancer in the U.S., isn't it?
That's right, yeah. In the U.S., we see about 8,000 people diagnosed each year. That figure includes both the intrahepatic and extrahepatic types, though the actual number might be a bit higher because, honestly, they can be tricky to diagnose sometimes. But, the really striking thing is the global picture. It's way more common in Southeast Asia.
And why is that?
It's largely linked to parasitic infections specifically, things called liver flukes, which are common in that part of the world. Also, it tends to affect older people more. The average age of diagnosis here in the U.S. is usually in the 70s.
Wow, that really underscores how geography and specific environmental things like those infections can play such a huge role in who gets certain cancers. Okay, let's shift gears now and talk about risk factors. What makes someone more likely to develop this type of cancer?
Well, researchers have pinpointed several factors, and a really common theme seems to be chronic or long-term irritation or inflammation of the bile ducts. So this includes certain diseases of the liver or the bile ducts themselves, like primary sclerosing cholangitis or PSC, that's a big one.
PSC, okay. What else?
Also things like bile duct stones, sometimes called hepatolithiasis, and cholelocystis cyst disease. And again, those liver fluke infections we mentioned, clonorchis and opisthoracis are the specific types. Also, having an abnormal bile duct anatomy, cirrhosis, which is scarring of the liver, and chronic infections with hepatitis B or C viruses, those all increase risk.
Interesting. Any links to other conditions?
Yes, definitely. Inflammatory bowel disease, so conditions like ulcerative colitis and Crohn's disease seem to be linked too. And then there are some genetic disorders like Lynch syndrome, BAP1 predisposition syndrome, cystic fibrosis. Things like that can increase susceptibility.
What about general factors? Age, ethnicity?
Yep. Older age is a factor, like we said.
Yeah.
And certain ethnicities and locations, for instance, Hispanic Americans in the U.S. seem to have a slightly higher risk. And globally, of course, Southeast Asia and China because of the liver flukes. Other things that might play a role include obesity, exposure to an old contrast agent called thorotrast, thankfully banned now, diabetes, both type 1 and 2, and maybe alcohol consumption, especially for the intrahepatic type.
And some less certain ones, too.
Right. The evidence is less clear, but things like smoking, chronic pancreatitis, possibly HIV infection, and maybe exposure to certain industrial chemicals, asbestos, radon, dioxins, PCBs, particularly in certain jobs, might also contribute.
So that common thread you mentioned, inflammation, it keeps coming up. How does that actually, lead to cancer developing? What's the mechanism there?
Yeah, it's a really strong connection. Scientists are figuring out exactly how this chronic irritation, this inflammation, can actually trigger specific changes in the DNA of the cells lining the bile ducts. Mutations, basically.
Right.
These mutations can do a couple of things. They might turn on genes called oncogenes, which are like accelerators for cell growth, making cells divide uncontrollably. Or they might turn off tumor suppressor genes, which normally act as the brakes, telling cells when to stop dividing or when to die off naturally. Now, most of these gene changes linked to bile duct cancer seem to be acquired during a person's life, rather than being inherited. Though, as we mentioned, a few inherited genetic disorders do increase the risk. For example, acquired changes in a well-known tumor suppressor gene called TP53 are quite common. And other genes like KRAS, HR2, ALK can also be involved in driving the cancer.
Okay, so given all those factors and the underlying biology, is this something that's, easy to catch early? Can we screen for it effectively?
Unfortunately, no. Not really. The bile ducts are buried pretty deep inside the body. So small tumors are really hard, basically impossible, to feel during a routine physical exam. And right now, we don't have any reliable screening tests like blood tests or specific procedures that can reliably detect these cancers early enough in people without symptoms. So the reality is most bile duct cancers are only found after they've grown large enough to start causing symptoms.
Right. So what are those symptoms? What should people, be looking out for?
The most common symptom by far is jaundice. That's the yellowing of the skin and the whites of the eyes. It happens because a tumor blocks the bile duct, causing bile to build up in the blood.
Okay, jaundice is key. What else might someone notice?
Intense itching is another common one. That's also caused by the buildup of bile components in the skin. You might also see changes in stool becoming light-colored or greasy. That's because the bilirubin, which gives stool its normal color, can't get into the intestine, and fats aren't being digested properly. And the urine might become dark as the body tries to get rid of that excess bilirubin through the kidneys.
Any pain associated with it?
Yes, sometimes. Abdominal pain, especially on the right side, just under the ribs, can happen if the tumor gets larger. Also, things like loss of appetite, unexplained weight loss, and sometimes even fever can occur.
But it's crucial to remember, right, that these symptoms could be many other things.
Absolutely crucial. These symptoms are far, far more likely to be caused by something much more common and less serious, like gallstones or hepatitis. But, and this is the important part, if you do experience these symptoms, you should definitely see a doctor right away to get checked out. Don't ignore them.
Okay, so someone has symptoms, they go to the doctor, and bile duct cancer is suspected. What's the diagnostic process look like? What tests get run?
Right, so it usually starts with the basics. A detailed medical history and a physical exam. The doctor will pay close attention to the abdomen, check for jaundice, maybe feel for an enlarged liver or gallbladder. Then comes a series of tests. Blood tests are usually first. They check liver and gallbladder function, looking at levels of bilirubin, albumin, and liver enzymes like AST, ALT, GGT, alkaline phosphatase. High levels can indicate a blockage or liver damage.
Do blood tests look for cancer markers too?
Yes, they often check for tumor markers like CEA and CA 19-9. Now, high levels can suggest cancer, but they aren't definitive proof at all. Lots of other conditions can raise these markers. They're actually often more useful for monitoring how well treatment is working later on, rather than for initial diagnosis.
Okay, blood tests give clues. What about actually seeing what's going on inside? Imaging tests.
Exactly. Imaging tests are critical. They use different technologies to create pictures of the inside of the body. Ultrasound is often the first imaging test done. It's easy, widely available, and doesn't use radiation. It can often show dilated bile ducts or sometimes even a tumor.
And if more detail is needed.
Then usually a CT scan, specifically a multi-phase CT or MDCT, is next. This gives really detailed cross-sectional images. It's great for seeing the tumor, figuring out if it's spread, and can even help guide a needle for a biopsy. An MRI scan is another powerful tool. It's particularly good for looking at soft tissues. And there's a special type of MRI called an MRCP that stands for magnetic resonance cholangiopancreatography. It gives excellent pictures of the bile ducts, gallbladder, and pancreas without needing to insert an endoscope.
So those are general imaging scans. Are there tests specifically for the bile ducts?
Yes, there are. Those are called cholangiography procedures. They involve injecting a contrast dye directly into the bile ducts to make them show up clearly on X-rays. One common one is ERCP, endoscopic retrograde cholangiopancreatography. It's a bit invasive. A flexible tube, an endoscope, is passed down the throat, through the stomach, and into the small intestine right where the bile duct enters. Then dye is injected, X-rays are taken. But the crucial thing about ERCP is that the doctor can also take small tissue samples, biopsies, or brushings from inside the duct during the procedure, and they can place a stent if needed to relieve a blockage.
What if ERCP isn't possible for some reason?
Then there's PTC, percutaneous transhepatic cholangiography. For this one, a thin needle is inserted through the skin on the right side, directly into a bile duct within the liver. Dye is injected, X-rays taken. Like ERCP, PTC also allows for collecting samples and placing stents or drainage tubes. It's often used if ERCP can't be done or didn't provide enough information.
Are there any other specialized tests sometimes used?
Occasionally, yes. Sometimes doctors might do a laparoscopy. That's minor surgery, where a small scope is inserted into the abdomen to look around directly, maybe check for tiny spots of cancer spread before planning a bigger operation. There's also cholangioscopy, which uses an even thinner scope, often passed through the main ERCP scope, to get a direct look inside the bile ducts and take targeted biopsies.
So lots of ways to investigate, but the final confirmation comes from.
The biopsy. That's the definitive step. Getting a sample of the actual cells or tissue from the suspicious area and looking at it under a microscope is the only way to know for sure if it's cancer. Samples can be collected during ERCP or PTC, like we mentioned, using tiny brushes or forceps. Or a needle biopsy might be done, guided by ultrasound or CT, where a needle is inserted through the skin directly into the suspected tumor.
And there's something important done with that biopsy sample now, right? Molecular testing.
Yes, exactly. This is a huge advance. Molecular profiling or testing is done on the biopsy tissue. This looks for specific changes, specific mutations in the DNA of the cancer cells. They test for genes like FGFR2, NTRK, IDH1, BRAF, RED, ARS, RR, and others. Finding these specific changes is critical because it can guide treatment choices, specifically pointing towards targeted therapy drugs that might work best.
Okay, so once cancer is confirmed by biopsy, the next step is staging. What exactly does that mean, and why is it so crucial?
Right, staging. Staging is basically the process doctors use to describe how much cancer there is in the body and how far it has spread. It's really important because it helps determine how serious the cancer is, and, critically, it guides the treatment plan. What's the best approach? The most common system used is the HACC-TNM system. T stands for the size and extent of the main tumor. N stands for spread to nearby lymph nodes, and M stands for metastasis, meaning spread to distant parts of the body. Now, specifics of the TNM stages are actually different for intrahepatic, perihilar, and distal bile duct cancers because their anatomy and spread patterns differ.
That sounds complex. Is there a simpler way doctors think about it for treatment?
Yes, for practical purposes, doctors often group bile duct cancers into two main categories for treatment planning: resectable or unresectable. Resectable means they believe, based on the scans and staging, that the cancer can be completely removed with surgery. Unresectable means it's spread too far, or it's in a location that's too difficult to remove entirely with surgery. Unfortunately, the reality is that most bile duct cancers are already unresectable by the time they're diagnosed.
Okay, that leads us directly into treatment. This is an area where there seems to be a lot happening, a lot of research. What are the main treatment options, and how do doctors tailor the approach?
Absolutely. Treatment decisions are highly individualized now. It really depends on several things: the cancer's location and stage, especially whether it's resectable or not, the potential side effects of treatment, your overall health, and importantly, your own personal preferences. It's almost always a team approach. You'll have surgeons, radiation oncologists, medical oncologists, gastroenterologists, radiologists, all collaborating. The main pillars of treatment include surgery, radiation therapy, chemotherapy, and then the newer approaches like targeted drug therapy and immunotherapy. And crucially, palliative therapy is integrated throughout.
Let's start with surgery. You mentioned it's key for resectable cancers, often seen as the best shot at a cure.
That's right. For the small percentage of patients whose cancer is found when it's still resectable, potentially curative surgery offers the only realistic chance for a long-term cure. But these are major complex operations. They really should be done at large cancer centers by surgeons who have a lot of experience with these specific procedures.
And the type of surgery depends on where the cancer is.
Exactly. For intrahepatic cancers, inside the liver, the surgery usually involves removing the part of the liver containing the cancer. This is called a partial hepatectomy, and sometimes it might mean removing an entire lobe of the liver. For parahilar cancers, near where the ducts exit the liver, the surgery is often even more complex. It typically involves removing part of the liver, the bile duct itself, the gallbladder, nearby lymph nodes, and sometimes even parts of the pancreas and small intestine. It's a big operation.
Wow. And for the distal cancers?
For distal bile duct cancers, further down the duct, the most common operation is called the Whipple procedure, or pancreaticoduodenectomy. This involves removing the head of the pancreas, part of the bile duct, the gallbladder, part of the small intestine, and nearby lymph nodes. Also a very major surgery.
We also talked about palliative surgery earlier for when cure isn't the goal. Can you recap that?
Yes, absolutely. When the cancer is unresectable, palliative surgery focuses purely on relieving symptoms and improving quality of life. This might involve creating a biliary bypass, essentially rerouting the bile flow around the tumor by connecting a higher part of the bile duct directly to the small intestine. Different types have different names, like choledochthojejunectomy or hepatocojejunectomy. Or, more commonly, it involves stent placement, inserting a small tube, usually metal or plastic, into the blocked bile duct to keep it open. This is often done less invasively during an ERCP or PTC procedure, and it can make a huge difference in relieving jaundice and itching.
And these major surgeries, they obviously come with risks.
Definitely. Beyond the general risks of any big surgery like bleeding, blood clots, infections, bile duct surgery has specific potential complications. Things like bile leaking from the reconnected ducts, liver failure, especially if a large part of the liver is removed, and long-term problems with digestion and nutrition because parts of the digestive system have been removed or rearranged.
Okay, moving on from surgery. How does radiation therapy fit into the picture for bile duct cancer?
Radiation can play several important roles, even though it's not always the primary treatment. It can be used as adjuvant therapy, meaning after surgery, to try and kill off any microscopic cancer cells left behind and reduce the chance of the cancer coming back. Sometimes it's used as neoadjuvant therapy before surgery to try and shrink the tumor, potentially making an initially unresectable tumor resectable, though this is less common. For advanced unresectable cancers, radiation might be used as a main treatment, sometimes combined with chemo, to help control the cancer and help patients live longer. Or, very importantly, as palliative therapy to shrink tumors that are causing pain or blocking the bile duct.
What types of radiation are used? Is it just standard external beams?
Often, it's external beam radiation therapy, EBRT, using sophisticated techniques like 3D CRT or IMRT to precisely target the tumor while sparing surrounding healthy tissue as much as possible. SBRT, or stereotactic body radiation therapy, which uses very focused high doses, might be an option in some cases too. What's really interesting, though, is the potential of proton beam therapy. It uses protons instead of X-rays. The unique thing about protons is they release most of their energy right at the tumor site and then stop, potentially causing less damage to tissues beyond the tumor. It's still being studied for bile duct cancer, but it's promising. There's also brachytherapy, or internal radiation. This involves placing radioactive sources directly into or very close to the tumor, often delivered through a catheter placed in the bile duct.
And side effects from radiation?
They depend on the area treated, but can include things like skin changes resembling sunburn, nausea, vomiting, diarrhea, fatigue, and potentially long-term damage to nearby organs.
Okay, let's talk chemotherapy. How effective is it, and how is it typically given?
Chemotherapy uses drugs that kill cancer cells. They're usually given intravenously, IV, or sometimes taken as pills, so they travel throughout the bloodstream to reach cancer cells almost anywhere in the body. Like radiation, chemo can be used in different settings. Adjuvant chemo after surgery to lower recurrence risk. Neoadjuvant chemo before surgery to shrink tumors. It's also a mainstay treatment for advanced or unresectable cancers, often combined with immunotherapy now, to help control the disease and extend survival. And it's crucial for palliative care, shrinking tumors to relieve symptoms.
Are there specialized ways to deliver chemo for liver-related cancers?
Yes, and this is quite innovative. One method is hepatic artery infusion, HAI. Chemo drugs are delivered directly into the hepatic artery, which is the main blood vessel supplying the liver and most liver tumors. This delivers a much higher concentration of chemo to the tumor while minimizing exposure to the rest of the body, potentially reducing side effects. Another technique is transarterial chemoembolization, TANCE. Here, tiny beads loaded with chemotherapy are injected into the specific artery branch feeding the tumor. These beads block the blood supply to the tumor and release the chemo directly into it over time. It's mostly used for primary liver cancer, but sometimes considered for intrahepatic bile duct cancer.
What are the common chemo drugs used?
Common drugs include gemcitabine, cisplatin, capecitabine, oxaliplatin, and 5-fluorouracil, 5-FU. Very often they're used in combination. The standard first-line treatment for advanced disease for many years has been the combination of gemcitabine and cisplatin, often called GemCis. Sometimes other combinations are used.
And the side effects of chemo, they tend to be more systemic, right?
Yes, because chemo drugs affect rapidly dividing cells throughout the body, not just cancer cells. So side effects often include hair loss, mouth sores, nausea and vomiting, diarrhea, increased risk of infection due to low white blood cell counts, fatigue due to low red blood cells, and easy bruising or bleeding from low platelets. The specific side effects depend on the drugs used and the dose.
Now, this next area feels like where things get really interesting and personalized, targeted therapies.
Absolutely. This is a huge area of progress. Targeted drugs are designed very differently from standard chemo. They work by specifically blocking certain changes or mutations within the cancer cells that help them grow and survive. The key thing is, for these drugs to work, your cancer cells must have the specific target the drug is designed to hit. That's why the molecular testing on the biopsy sample is so critical.
So what are some examples of these targets and drugs in bile duct cancer?
There are several now. For cancers with changes in the FGFR2 gene, there are FGFR2 inhibitors like pemigatinib and futibatinib. For cancers with mutations in the IDH1 gene, there's an IDH1 inhibitor called ivosidenib. For rare cancers with NTRK gene fusions, there are TRK inhibitors like larotrectinib and entrectinib. For those with ADAT rearrangements, there are ARAT inhibitors like selpercatinib and pralsetinib. For BRAF V600E mutations, a BRAF inhibitor like dabrafenib is often used, usually combined with an ME inhibitor like trametinib. For KRAS G12C mutations, there's a KRAS inhibitor called adagrasib. And for cancers that are HER2 positive, targeted therapies like zanidatamab are being used or studied.
That's quite a list. How are these usually taken? And are the side effects different from chemo?
Many of these are pills taken orally, though some are given by IV. And yes, their side effects are generally different from traditional chemo. They tend to be more specific to the pathway the drug is blocking. For example, FGFR2 inhibitors might cause nail problems or eye issues. IDH1 inhibitors can sometimes affect heart rhythm. It really varies by drug.
And the other major breakthrough area? Immunotherapy, using the body's own immune system.
Yes, immunotherapy has been another game changer, particularly for certain patients. The main type used in bile duct cancer involves drugs called immune checkpoint inhibitors. Basically, cancer cells can sometimes put brakes on the immune system by displaying certain proteins on their surface, like PD-L1. This tells immune cells, like T cells, not to attack. Checkpoint inhibitors block these signals, effectively releasing the brakes and allowing the immune system to recognize and fight the cancer.
What are the main checkpoint inhibitors used?
The most common targets are the PD-1 protein on T cells or the PD-L1 protein on tumor cells. So PD-1 inhibitors like pembrolizumab and nivolumab were used. Pembrolizumab, for instance, can be used alone for tumors that have specific features indicating they might respond well to immunotherapy, like being MSI high, MSIH, DMMR, or having a high tumor mutational burden, TMBH. Perhaps more commonly now, pembrolizumab is often combined with standard chemotherapy, gemcitabine and cisplatin, as a first-line treatment for advanced bile duct cancer, regardless of those specific markers. There's also a PD-L1 inhibitor, durvalumab, which is also used in combination with chemotherapy. And sometimes a CTLA-4 inhibitor like ipilimumab, which blocks a different checkpoint on T cells, might be used occasionally in combination with nivolumab.
How are these given? And what about their side effects?
These are typically given as intravenous infusions, often every few weeks. While they can be very effective, they can also cause significant side effects. Besides infusion reactions, the main concern is autoimmune reactions. Because you're taking the brakes off the immune system, it can sometimes mistakenly attack healthy organs and tissues, leading to inflammation in the lungs, intestines, liver, hormone glands, skin, or other parts of the body. These need to be managed carefully.
Okay, and finally, let's just touch base again on palliative care. You've mentioned it a few times, emphasizing its importance throughout.
Yes, it's absolutely vital to understand that palliative care is not just end-of-life care. It's focused on preventing and treating symptoms and side effects, improving comfort and quality of life at any stage of illness, even alongside curative treatments. So beyond managing pain, nausea, fatigue, and itching with medications, it includes procedures we've discussed, like biliary stenting or bypass to relieve blockages. It can also sometimes involve tumor ablation techniques. These use focused energy like heat from radiofrequency ablation, RFA, extreme cold from cryosurgery, or injecting alcohol to destroy small tumors, usually in the liver, or even photodynamic therapy, PDT. This involves injecting a drug that makes cells sensitive to a specific type of light, then using a laser delivered via an endoscope to activate the drug and kill tumor cells blocking a bile duct. Again, these ablation or PDT procedures usually aren't meant to cure, but they could be very effective at shrinking tumors to relieve symptoms like blockages or pain.
So, putting this all together, for someone living with or beyond a bile duct cancer diagnosis, what's the general outlook? How do we interpret survival statistics?
Right, survival rates. They're complex, and it's really important to approach them with the right perspective. We usually talk about 5-year relative survival rates. This compares people diagnosed with bile duct cancer to the overall population. Using data from a large U.S. database, year from 2012 to 2018, they categorized survival based on how far the cancer had spread at diagnosis, localized, regional, or distant. For intrahepatic bile duct cancers, the 5-year relative survival was about 23% if it was localized, 9% if regional, and 3% if distant. The overall combined rate for all stages was 9%. For extrahepatic bile duct cancers, it was 18% for localized, also 18% for regional, and 2% for distant. The overall combined rate here was 11%.
Those numbers can feel daunting. What's the critical context to keep in mind?
Several things. First, these are averages based on large groups of people diagnosed several years ago. They absolutely cannot predict what will happen to any individual person.
Okay.
Second, they don't account for individual factors like your age, your overall health, how well you respond to treatment, or the specific molecular features of your tumor. And maybe most importantly, treatments are constantly improving. The targeted therapies and immunotherapies we just discussed have really changed the landscape, especially in the last 5–10 years. So people diagnosed today may genuinely have a better outlook than these historical statistics reflect.
That's a really important point. So, for survivors, those who've completed initial treatment, what does life look like afterwards? What about follow-up?
Follow-up care is absolutely crucial. Regular checkups are needed to monitor for any signs that the cancer might have come back, recurrence, and also to manage any long-term side effects from treatment. Typically, this involves visits every 6 months or so for the first couple of years, then maybe annually after that. These visits usually include a physical exam, blood tests, including liver function, and tumor markers, and often imaging scans like CT or MRI. One specific long-term issue to watch for after surgery is the development of strictures, which are non-cancerous scars that can narrow the bile ducts and sometimes cause symptoms similar to the original cancer, like jaundice or pain. These might need treatment like stenting. It's highly recommended that you work with your doctor to create a formal survivorship care plan. This document summarizes your diagnosis, the treatments you received, and outlines a plan for future checkups, screening for late effects, and suggestions for maintaining your health. And practically speaking, keeping good health insurance and maintaining copies of your medical records is also really important.
What about lifestyle changes after treatment? Can things like diet and exercise reduce the risk of the cancer coming back?
That's a common question. Currently, there's no definitive scientific proof that making specific lifestyle changes can directly lower the risk of bile duct cancer progressing or recurring. However, adopting generally healthy behaviors is always a good idea for overall health and well-being, and may help you cope better with recovery and reduce the risk of other health problems. So, things like not smoking, limiting alcohol intake, eating a balanced diet rich in fruits, vegetables, and whole grains, getting regular physical activity, and maintaining a healthy weight. These are all beneficial. It's also really important to be cautious about dietary supplements. No supplements, including vitamins or herbal products, have been proven to reduce bile duct cancer recurrence. Some could even be harmful or interfere with ongoing medical treatment, so always discuss them with your doctor first.
And finally, dealing with cancer isn't just physical. What about the emotional and financial impact? What support is available?
That's incredibly important. It's completely normal to feel depressed, anxious, worried, or overwhelmed at various points during and after cancer treatment. It's a huge life event. Getting support is key. This can come from friends, family, cancer support groups, either in person or online, or through professional counselors or therapists who specialize in working with cancer patients and survivors. Don't hesitate to ask your care team for referrals. Financial concerns are also a major stressor for many families dealing with cancer. The cost of treatment, travel, time off work, it all adds up. It's really important to talk openly about these concerns with your hospital social workers, patient navigators, or financial counselors. They often know about resources, assistance programs, and ways to manage the financial burden.
What an incredibly thorough deep dive. We've really covered a lot of ground, from the basic anatomy of the bile ducts, the difficulties in early detection, the complex risk factors, all the way through to the sophisticated treatments available today. Intricate surgery, precise radiation, chemo, and especially those game-changing targeted therapies and immunotherapies.
It's definitely a complex picture. The journey for anyone facing bile duct cancer is challenging, there's no doubt. But the pace of research, the new understanding of the molecular drivers of this disease, and the resulting personalized treatment options really do offer significant hope. It highlights the incredible progress happening across oncology, really driven by getting smarter about how cancer works at its most fundamental level.
Absolutely. And as we've seen today, even for a cancer that's considered rare, the speed of discovery and this shift towards personalized medicine are constantly changing what's possible. It leaves me thinking, how might these powerful insights from genomics, from immunology that are revolutionizing cancer treatment, how might they ripple outwards and impact how we think about or manage other areas of health, maybe even things in our daily lives? Something for you to ponder. Until next time on The Deep Dive, keep exploring, keep asking questions, and keep learning.